My name is Jonathan Cordova. The topic of my talk is to discuss a little bit about transition of care from pediatrics to adult GI. All right, so there's my mugshot. Again, I'm a pediatric gastroenterologist. I work outside of the suburbs of Chicago in the northern part for a hospital system called North Shore University Health System. I'm the co-director of our Pediatric IBD Center. Within this partnership that's developed over the last couple of years with some hospital systems in Chicago, we're now called the Chicagoland Children's Health Alliance, which involves my hospital, North Shore, Advocate Children's Hospital, which is a big hospital system within Illinois, and recently added University of Chicago Comer Children's Hospital. And again, the disclosures from the conference itself. So healthcare transition is really important. We define this in the medical field as a purposeful, planned movement of young adults who suffer from chronic medical conditions from the pediatric or child health system more towards the adult healthcare system. We recognize that we have to prepare our youth for this type of transition. Preparing them to enter into adulthood, into taking responsibility of their own care is really an essential part of pediatric care. A lot of what we do in pediatrics is preventative medicine, growth development, and this is a vital part, especially for young adults and adolescents. So we do incorporate this, or we recommend that we incorporate this or bring this up with your pediatric GI provider early on. So there's some principles of transition to make sure that this is a successful transition period. We really want to make sure that we're not compromising a young person's current treatment plan or management strategy. You know, in an ideal situation, this is multidisciplinary with the involvement of both pediatric and adult providers who work together, understanding that in the healthcare system that we do work in, that may not be as easy of a feat as we'd like it to be. But we also want to make sure that we're involving both patients and their families in this transition process. So this is a nice schematic. If you want to think about the left side of the diagram as more the pediatric, and we're moving towards the right side, which is more the adult care. Really in early, childhood with disease, a lot of the responsibility and the knowledge that we expect really comes from parents, right? We're educating parents. We're also educating the child, but understanding and recognizing that the responsibility weighs more heavily on the parent for some decision making. As we enter into our teenage years, we really want to start to promote and advocate for our patients and our young teenagers and young adults to start to take a little bit more ownership of their disease, of their medications, understanding that once they become an adult and transition over to an adult GI, that the responsibility really lies with them and not with their family members. We also have to recognize and understand that really young adults are a special population. So young adults between the age of 12 and 26 make up about 20% of the population here in the US. We have to recognize, and I think most of us do recognize, that this stage of life really has to do with a lot of change. There's growing independence. Kids are becoming, self-determined. This is a period where risk-taking behavior can start to peak. And unfortunately, we do see some chronic conditions, not IBD specific, but they're often exacerbated in this teenage. Puberty, hormone changes, all of that can affect both mentally and physically kind of how your disease is behaving. We as pediatricians and pediatric GI providers go through a pediatric residency, so we are well aware of kind of the developmental changes that can happen in adolescence. We recognize that, again, this is a unique population. But understand that, our adult colleagues may not have this specific training. So they're starting to recognize more so in the adult medicine world that, yes, patients who are diagnosed with chronic diseases at a young age are starting to learn how it may affect their growth, their development, even their mentation as they transition to adulthood. This is just a quick slide just to describe, again, how adolescence is a very special time. So, we recognize that the brain continues to develop even after it's done growing. So we understand and recognize that the brain really reaches its biggest size in early adolescence, 13, 14, 15, but that it continues to mature even after it's done growing. There is this part of the brain called the prefrontal cortex, which lives in the front. That's really responsible for planning, prioritizing, impulse control, and this doesn't really stop maturing until really the mid to late 20s. So you can recognize and understand that, again, the transition period from late teenager to young adult, there's a lot of growth that's still happening in the brain. We do recognize that the brains are adaptable. But we do recognize also in teenage years that this can be a period where we start to see the development of some mental disorders. Anxiety, depression can start to peak or show up. So we need to take that into account when we're starting to discuss transition of care. Teen brains have been studied, been shown to be more vulnerable to stress. Sleep is really important. The teenagers, many of us probably remember or have teenagers, do require lots of sleep, but do recognize that the brains are very resilient. As a pediatrician, again, we go through many milestones, especially in the early infancy years as a general pediatrician, recognizing growth and development milestones. But there are some milestones that we need to recognize in the adolescent period. In our early teenagers, again, a lot of hormonal changes, puberty starting, the importance of what your friends and your peers really think. Physical appearance is really important. So we need to understand as we start to talk more about disease-specific medications, how their disease is behaving, and then ultimately how we're going to transition. We need to take into account kind of where their level of maturity is. As we get a little bit older, obviously we recognize that independent thinking starts to take into a place. We discussed a little bit about the risk-taking behavior. Some rational decision-making is starting, but it's not yet fully developed. And then once you do turn into an adult, there really is that powerful, focus on self. You're really starting to think about the future possibility, but that also brings in some fears about potential instability depending on how your disease is behaving. So now more specifically with inflammatory bowel disease. So, we heard earlier this morning kind of the different spectrums of ages from young children with IBD into our elderly, but we recognize now that about 25% of patients with inflammatory bowel disease are really diagnosed before the age of 18. So we're seeing an increasing prevalence and incidence of IBD in children. We also heard earlier this morning, and I'll reiterate that, those kids, we tend to see more aggressive disease. They tend to have a phenotype or a characteristic, a display of more extensive disease, and again, may require more extensive medicines. And then obviously with our medicines working as well as we want them to work, most of our patients are really requiring, and it's a necessity to leave the pediatric care and eventually transition to an adult GI, hopefully with IBD experience. And again, this transition really should take some careful preparation and make sure that we're coordinating well with patient parents and providers to avoid any interruptions in their care. Again, this time period in IBD, we start to think about when kids really start to transition or think about transition. Just because you turn 18 in my practice, and most providers will say, doesn't mean a hard stop of you have to start seeing an adult GI. I don't know if that time is specific, exactly the right time to change, because there are lots of changes that are happening. Many of our young patients are starting college, they're moving away from home, they may become financially independent, they may be entering the workforce and or the military. And so this is a risky time for patients potentially to have some poor outcomes or some losses in their care. We want to make sure that we minimize those as much as possible. So the key elements to transition, when I really think about this, we're transferring care from, again, if you remember that slide earlier, from the parent is taking most of the responsibility. Now we're transitioning that over to our patients taking most of the responsibility. And similarly, we're doing the same from our adult providers and our peds providers. We're transitioning the care from a pediatric GI to an adult GI. And if these aren't working in tandem together, inevitably we're gonna have poor outcomes and a setup for failure. So this process, again, should be gradual. It should not be sudden. We don't want to jump from one provider to the other without communication, recognizing that for some patients, this can take months. For other patients, it can take years. So this is really an individualized approach to make sure that when it's time, that everybody's ready to make that next step. We should take into account what patients and parents, what their preferences are. Oftentimes in my practice, kids will move away to college, but recognize that place where college is, whether it's in a different state, may not be the ultimate place where they're going to end up and live, and they think they're going to come back home. So my practice is not to transition that patient through college, rather to transition them when they figure out exactly where they may be for a majority of their time post-college. Transition can sound daunting, right? It's something that can be difficult to discuss when we get there. But once the process does begin, most studies will say that, young adults and families really adapt pretty quickly, and it can be a positive experience. So this is just a quick schematic. Healthcare models in pediatrics in the States versus adult can be a little bit different. This can go through a little bit of differences between both. So in pediatrics, we're really multidisciplinary, and if you look at the focus of care is really on the family as a unit. So obviously we're treating the patient, but we're taking into account family preference, parent preferences. In adult medicine, again, you're going to see an adult gastroenterologist, hopefully with some IBD experience, but really the focus of care now is on the patient specifically as opposed to the family as a unit. So again, we're focusing more on autonomy of the patient, making that decision-making on their own as opposed to focusing on this as a collaboration with families, okay? With regard to endoscopy, so this is something that becomes important. In pediatrics, the standard of care is to have an endoscopy or colonoscopy done with an anesthesiologist present. So they're the experts that work on putting kids to sleep. As pediatrician and pediatric GI, we don't get training in that, which is different than the adult world. The adult gastroenterologists often do have training in what we call conscious sedation, being able to anesthetize patients and perform their own sedation while they do their own procedures, although recognizing that if there is certain instances that anesthesiologists can be present. So that's one little nuance that we can find a little different there from a scoping standpoint. And, if you do end up in the hospital in pediatrics, most kids will end up in a pediatric ward in a children's hospital or the pediatric ward of an adult hospital where parents can stay with them, 24 hours a day, stay overnight. Contrast to adult medicine, they're often, on an adult floor where family and visitors really have to pay attention to visiting hours, so may not be able to stay with you 24 hours a day. How about barriers? So there are barriers, from all aspects of, why it may become difficult to discuss transition or to actually follow through with transition. Obviously, from the parent and family standpoint, there may be reluctance to change providers, anxiety about changing providers. Again, if we're diagnosing kids very young, 5, 6, 7, even 10 years old, we've been with that provider, we've been with that family for well over 5, maybe even 10 years. It can be difficult to let go and feel like we're going to get the patients are going to get the same care with an adult. There's also some hesitancy or some parents may not be unaware that they really need to advocate for their child to take some responsibility in their early teenage years or late teenage years and let them kind of self-manage, because this is a skill they need to learn, again, when they transition over to the adult side, okay? Young adult patients, kind of the same concept, difficulty letting go of a trusted provider that they've established a good rapport and a relationship with over the last several years. And then again, another finding of, again, some mental diagnosis can show up here, so that can make a barrier to transition. With regards to peds, we as providers also have a hard time letting go, right? So we feel like we take a lot of ownership and pride in the growth and the development of these kids. So it can be hard for us to let go. We also have a hard time making sure that we're finding the right provider for the patient. In adult GI, not everybody is an IBD expert, so I'm glad that you're here at these conferences, and the goal is to really find the right provider who's going to take over care, but those are some of our barriers as well. And then there may not be a formal transition protocol. So if you're in a big academic center, there likely is an adult GI IBD clinic where that transition process may be a little bit easier. But if we're in a rural area or part of potentially a private practice in pediatrics, there may not be that smooth protocol or transition to get over to an adult GI. So those can be some barriers. For adult providers, again, I touched on this a little bit earlier, but there may not be that specific training in recognizing or caring for young adults who had disease that started pretty early on in life, and for them to recognize the impact that maybe it played on their growth and development as a young child. And then again, keep hitting this point, but adult medicine really does interact or relies mostly on that interaction between the patient and the provider, oftentimes without the family involved. And again, that can pose a little bit of a barrier. So for patients specifically, for families specifically, this is kind of the key point, the takeaway of, at a minimum, what do I need to know about my disease when I start thinking about transition? I have my patients understand and recognize, what's the name of the disease? We've talked about Crohn's and colitis, or ulcerative colitis. Now there's this indeterminate colitis that Dr. Stevens mentioned. But how old were you when you were diagnosed? If you have Crohn's disease, where is your Crohn's disease located? Is it high up in my intestine? Is it in my small intestine, which is called the ileum? Is it in my colon? We call that colonic. Or is it in my ileocolonic, meaning it's the small bowel as well as the colon? So that's important. Those are terms that are important to understand and recognize. Ulcerative colitis, it's important to know, do I have colitis or inflammation everywhere in my colon? Is it limited to the left side, or is it limited to the rectum? That's called proctitis. Or this concept of indeterminate colitis, meaning, I haven't been able to fit you into that one silo of Crohn's disease or ulcerative colitis. There may be features of both. Understanding if your doctor's giving you that term, what that means. Names of medications are really, really important. I start this even younger than my early adolescents and my young children. I want them to recognize or understand the name of their medicine. I don't intend them to understand the mechanism of why things work, how they work, but knowing the name of the medication. As you get older, knowing the dose of the medication that you take and how often you take that can be really, really important. And then what medicines you've tried in the past. You don't have to, understand or recognize, again, every medicine, but understanding that you've tried 2 or 3 medicines and potentially why they stopped working can be really helpful, okay? And then understanding when your last colonoscopy. These are things that the adult GI provider, when they see you for the first time, these are the questions that they're going to ask, okay? These are the important takeaway for them to understand where your disease started and where you've come over the last several years. So key points for the patient, and I put the word "you" here. This is driven more so towards the patients. Again, we're taking responsibility for their own healthcare decisions. The patients really understand and recognize how to monitor their own symptoms. They know who to call if they're not feeling well. When they're young children, they're telling mom and dad. Mom and dad are calling the office. The office is getting back to the parent. Now the ownership really is on the patient to take that responsibility, okay? Keeping track of appointments is another really important thing. So again, most teenagers often don't understand or recognize or know when their appointments are. Their parents tell them when it is, right? So now that you're an adult, our adult colleagues are expecting the patient to keep track of that and to attend those appointments. If they can't, it should be the patient who calls in advance to cancel or reschedule that appointment. That's really important. Taking medications, again, this is another ownership of, now, mom and dad or our caregivers may not be there to give us our medications. We need to make sure that we're taking them the way that they're supposed to. And then again, to some degree, understand how those medications are getting paid for, okay? In the United States, most young adults will be on mom and dad's or a caregiver's insurance until maybe the mid-20s. I think it's 26. But understanding and recognizing that eventually, somebody has to pay for that medication. Understand a little bit about insurance coverage. This is a nice checklist that comes from our NASP, again, sorry for the typo, which is our Pediatric society here in the United States. But this is a nice checklist that's age appropriate, early adolescence, mid-adolescence, late adolescence, and just checklist questions that you should start to understand and recognize with regard to your disease, things that we would expect our young patients or young adults to understand and recognize to give us the good sense that, hey, I understand what's going on with my body, with my disease, with my medications, and then eventually as we're hitting that late adolescence, am I ready to transition? So take-home points, it was a quick talk, but healthcare transition is really important, especially in inflammatory bowel disease, these chronic diseases. Recognize that the transition really is a complex process. You like to start this early in adolescence to give kids enough time. Remember that every patient's different, every transition is going to be individualized, but we really do want to make sure and recognize that this is a unique population, make sure that everybody's comfortable and ready to transition, but not to be scared of transition, okay? We need to empower our patients or young adults to take ownership of their disease, and then I also challenge both the pediatric and the adult providers to really collaborate well with each other, again, to make a smooth and seamless transition. And then my last slide, these are just some resources online that can help. The My Health Passport is not specific to IBD, but if you go on that website, there's actually a drop-down menu. You can click Crohn's or colitis, and it will walk you through 15, 20, 30 different questions where you can just click certain drop-downs, add some free text with regard to medication, disease, location of disease, and then ultimately it will print out a card that you can carry with you at all times. So that's My Health Passport. Medical ID, most smartphones have this feature, so the iPhone has this feature. You can go into the medical ID through, I think, the general tab, and you can put some information in case of an emergency, EMTs, ambulances, ERs. If you're unable to communicate and they find your phone, they can access that from the lock screen. That'll give them a breakdown of maybe what medications you're taking and or your disease. Just like MyIBD through the CCFA website is a great resource for teenagers just to get a lot of information, age appropriate. And then the Doc4Me app is another app that's sponsored by our NASPGHAN Society. This is a great app I make sure all my college kids have when they leave. This gives you the ability, it's a free app, it gives you the ability to put in a zip code and it'll find an adult GI provider who specializes in Crohn's and colitis in that area. So as my kids leave for college, whether they've transitioned or not. I have them, download this app, find a provider, get a name and a number, save it in their phone. But again, this can be used at any point in time. And with that, I'll take any questions.